Greetings, everyone, and welcome back to the ECG Case of the Week for the week of May 20th, 2019. This is Amol Mattu at the University of Maryland School of Medicine, and welcome back to this week's workout. Well, this week, the theme is this. On the road to success, there are no shortcuts. Now, what in the world am I talking about? Well, this is kind of a humorous picture, but it's also an important thing to keep in mind, and actually I have to tell you that this week's ECG workout is, on my part, going to be somewhat of a rant. I'm really bothered by something that I've seen in all too many scenarios, and so what I'm going to do is try to convince you that a practice that exists out there is really not a good idea. And so anyway, we're going to kick this rant off by starting with this case. This was sent very recently by Dr. Annalee Baker. She's the Emergency Medicine Clerkship Director at Aventura Hospital in Florida, and she sent in a really, really great teaching case. This is a 64-year-old man who presented with a history of hyperlipidemia, hypertension, comes in with persistent chest pain, nausea, vomiting, shortness of breath. So this is obviously a concerning story. On top of that, this patient's looking relatively sick. They get a 12-lead ECG, and the computer is calling this normal. Now, what you could do is just say, well, at triage, the computer's calling this normal. This patient can probably just go back and sit in the waiting room until a bed opens up. But Annalee was a little bit smarter than that. What she did was she took a look at the 12 lead, and she was concerned about lead AVL. And I know we've talked about this before, and we're going to really try to hammer this home again today. That's one of the key take-home points today. When a patient's having acute chest pain and you see a new flip T wave, even if you don't know it's new, but if you see a flip T wave in lead AVL, one of the things that you've got to worry about is that is an impending inferior wall STEMI, or at the very least, inferior wall ischemia. And what do? Well, you're not going to activate the cath lab for this. There's not really enough ST segment elevation necessarily. I mean, I guess you could say that there's about a millimeter in the inferior leads, but the computer's calling this normal. What you do in this case is you simply get a repeat 12 lead to confirm your suspicions or to refute your suspicions. That's exactly what she did. This repeat 12 lead was done just 30 minutes later, and take a look now. AVL's gotten worse, but you may also happen to notice that the inferior leads have gone amok. They are turning into a very obvious inferior wall STEMI. There's also some lateral wall involvement. And by the way, hey, the computer's on board with this as well. Acute STEMI. Thank you very much, Mr. Computer, for joining the party and calling this an inferior wall STEMI. Key point here was, number one, flip T-wave in AVL. She was not content to just call it normal. She got a repeat 12 lead looking for inferior badness, and that's exactly what happened. Key point number two, she did not believe the computer, even though the computer said it was normal. Key point number three, when you ever have any concerns, get a repeat 12 lead in 20 minutes, 30 minutes, in an hour, I don't care when. Just get a repeat 12 lead at some point in the near future, and you may be very surprised at what you end up finding. And no surprise, this turned into a right coronary artery occlusion. The patient had a fantastic outcome. So this is the way cases are supposed to go. Congrats to Annalee for making the diagnosis here. But that's not what I want to talk about. I don't want to talk about cases that go well. I want to talk about the mistakes that oftentimes make. Number one, key point from this case. Again, I've mentioned all three of the key points we're going to go through. Don't trust the computer interpretation even when it's normal. Even when it's normal. Or let me say it another way, even when it's normal, don't trust the computer interpretation. If the computer says it's a STEMI, don't trust it. You've got to read it yourself no matter what the computer says. Second key point, again, T-wave inversion in AVL in symptomatic patients, not asymptomatic, but symptomatic patients can be an early predictor of an inferior wall STEMI. So key point number three, get the repeat 12 lead when there's any possible concerns that you have. If a first EKG is not diagnostic, get a repeat in a little while. I'm not saying you have to repeat it every 10 minutes for 3 hours, but just at least, for God's sakes, get one repeat EKG. So what set me off this week to talk about this? Well, somebody sent me a case very recently where they got a 12-lead ECG at triage. The 12-lead ECG at triage was read as normal, so nobody looked, at least none of the physicians looked at the patient, or they looked at the ECG. They had kind of a pseudo policy which said, partly based on this article, and they sent me this article, and they said, well, when the 12-lead ECG is read by the computer as normal, we assume, we've been told that that's pretty reliable, and the patient probably can go back out and sit. We don't have to look at the ECG right away. And perhaps this is one of the sources of that mistake. And this is the conclusion from the article: eliminating physician review of the triage ECGs when the computer says normal may be a safe way to improve patient care by decreasing physician interruptions. And I agree with this, except for the word safe. It's not a safe thing to do. I think this is an interesting study. It was a nice study, but it only had 222 normal ECGs as the N in the study. That's way too small of a study to change your practice on. Bottom line is, you cannot rely on the normal 12-lead ECG that the computer read as normal at triage. You've still got to immediately look at the 12-lead. And I know people want a way out of doing this. I know how annoying it is to be working hard and people keep bringing these ECGs from triage and you need to sign off on these ECGs. You know what? Just suck it up. You've got to do it. It's part of what we do. It's part of our practice. You've got to look at the 12-lead ECG when they get done. Otherwise, bad things are going to happen, like what happened in this case. I can't show you the case. It certainly is already involved in review, and maybe that article will be helpful in that particular case, but it certainly isn't helpful to the patient who had a bad outcome. This week, just as part of my rant, I want to go through 10 more cases. So get your popcorn, sit back, and watch as we go through these 10 cases where the computer messed up. And I'd love to use a word different than messed up, but I'm just not going to do that. So case number 1, and we've, by the way, gone through these cases over the past few years, but I put them all together today just so that we can really hammer home this point. Mike Barca, a senior resident from New York, sent this case. 64-year-old with chest tightness, radiation, diaphoresis. These are all bad things, so he was obviously worried about the patient. And again, take a look. Normal 12-lead ECG, but Mike was concerned about more than that. Lead AVL, again, has that flip T wave, and so he was worried about the potential for inferior badness. Notice again, the patient is actively having pain. That's when we worry about this. He gets another 12-lead 30 minutes later. Hey, take a look at what's happening to AVL. It's starting to look worse, and the inferior leads are starting to elevate, and he gets another one 20 minutes later after that, and finally the computer's on board. This is a full-blown inferior wall STEMI. Cardiology agrees to take the patient to cath. Unfortunately, the patient has a VFib arrest before the cath, but fortunately, they defibrillated the patient, and I think this patient ended up having a pretty good outcome. And there is your culprit lesion, the RCA. There is also distal LAD and left circumflex. It's actually 3 culprit lesions in here. Patient ended up having to go back to the cath lab a couple of times. Case number 2, this one's from Canada. So this is not just a U.S. thing. Those folks up in the Great White North ought to take heed of this also. They probably already know about this, but I'll show you a case from up in Canada as well. 79-year-old with chest pain, radiation, that's bad. And again, there's your computer trying to mislead you, because that's what computers do. They try to mislead you. And there's your AVL finding once again. So I'm going to show you a whole bunch of these AVL findings, because this is something that I think the computer is particularly rotten at. The computer does not appear to pay any attention or much attention to AVL, but we have to, because this is such a common thing. Interestingly, the patient had been in the ED a week earlier, and let me blow up AVL for you. So there's your AVL a week earlier. It's flat, fairly isoelectric, and now it's a little bit depressed, and the T wave is inverted. Those are early reciprocal findings in a person that's having an inferior wall STEMI. So Dr. Chung gets a repeat. He doesn't bother waiting. It just says, look, I'm going to do it right away. So 13 minutes later, there is your inferior wall STEMI, and AVL is looking a whole lot worse. So that's case number 2. This patient ended up having, there's your infarct-related artery, proximal and mid RCA. Another case, this one's from Nashville. 27 years old, 27. You would think it's too young to be having an MI. You're never too young to have an MI in first world countries with the rotten diets that we have. This patient comes in with 1 out of 10 chest pain, and it's about 5:30 p.m. Here's what your computer is reading, this early repull, but otherwise pretty much normal. Normal ECG. Early repull is a normal variant. We're not going to worry about that, right? Well, there's a problem here. You really shouldn't call something early repolarization when you have a flip T wave in AVL. So Anna Marie was appropriately concerned. She decided to get some serial ECG. So again, here's the first one at about 5:33. There's the next one at 6:07 p.m. AVL's looking worse, and you see the STs are starting to rise more. By the way, take a look, straightening on the initial part of the T wave. We've talked about that as a hyperacute finding. The initial part of the T wave should be concave upwards, like what you're looking at there. When you see straightening on the initial part of the T wave, that's a sign of early ischemia until proven otherwise. How do you prove otherwise? Can you cath them in the emergency department? Of course not. So what we do to prove otherwise is we simply get some serial ECGs. So let's get another ECG on this patient, and there you go. There's your full-blown, no-brainer, inferior and lateral wall STEMI. This 27-year-old had triple vessel disease. The computer called it normal. And what you did, what Anna Marie did, was picked up on the AVL abnormality that the computer very conveniently ignored. Case 4, this is from our emergency department. Take a look, 55-year-old woman coming in with atypical chest pain. Computer calls this normal, but we're not settling for normal. We see that there is some slight ST segment sagging and a flip T wave in AVL. There's also a little bit of J point elevation in the inferior leads. Is that early repolarization, or is that an early inferior STEMI? Well, again, with that T wave abnormality, you can't really reliably call that early repol. You've got to assume badness. One other thing that is always worth doing when you see something that looks awry, get an old ECG. There's the prior, and there's AVL. That's what it's supposed to look like. It looks like a nice AVL. About 15 minutes later, the patient has a big-time inferior wall STEMI. The patient actually had a cardiac arrest very shortly after this ECG was obtained, and fortunately had a very good outcome. Thankfully, she was on a monitor. We didn't just put her back out in the waiting room based on a normal triage ECG. Case number 5, 56-year-old, comes in with throat burning, nausea, belching, couple cardiac risk factors. There's the initial ECG, and your computer is trying to fool you again. Normal ECG, wrong. That is not normal. You can't call something normal when you've got a flip T wave in AVL in a symptomatic patient. And throat burning, belching, that's his anginal equivalent. Is it possible it's just reflux? Yeah, of course it's possible. But when you've got this abnormality, you've got to do something. What are you going to do? Hey, here's a novel idea. How about a repeat 12-lead ECG? So that's what we did. 30 minutes later, here's the repeat. Take a look. AVL's getting worse, and your inferior leads are now starting to rise. Well, if you're not convinced by that, by the way, there's also a little bit of reciprocal depression in V2. If that's not solid enough for you, let's get another ECG 15 minutes later. Now, it's a no-brainer, inferior wall STEMI, and it all started out with the triage normal 12-lead ECG. Case number 6. Here's a guy with substernal burning and diaphoresis, and here's his 12-lead. The machine's calling it normal. Not even early repol, but it's just calling it normal. Well, maybe there's a little bit of early repolarization there and out there, but there's a flip T wave in AVL. No, don't call it early repolarization. What should you do? Get a repeat 12-lead, and here's the repeat 20 minutes later. And if that's not good enough for you, how about this one another 10 minutes later? Full inferior and lateral STEMI. Fortunately, the patient ended up doing well. Normal initial 12-lead. Case number 7. We're almost done, folks. Hang in there. Let's get away from AVL now, okay? We've talked a lot about how the computer tends to ignore AVL. Here's the other thing that the computer tends to ignore in my experience. The computers tend to be really bad at picking up hyperacute T waves, the big T waves. The computers just don't pay attention to that, in my experience. Case number 7, 62-year-old woman with malaise, lightheadedness, mild nausea. She's got diabetes. That means she's a setup for atypical presentation. And there's her atypical presentation. There's atypical. There's atypical. Well, they did the right thing by getting a 12-lead, but they did the wrong thing by thinking that this is normal. Well, what's abnormal about this? Maybe there's a little bit of downsloping AVL, so we've got to worry about that. Hopefully everybody's in tune with that. Here's the baseline, and let me put these next to each other so you can really appreciate the difference here. I'm not even going to point at AVL, but the key difference here, this is your baseline, and this is now, and I think what you hopefully appreciate is there's big, tall T waves in V1 and V2, which are new, and something that we've talked about a couple of times before, when the T wave in V1 is much larger than the T wave in V6 in a symptomatic patient. That's something that Marriott described many years ago as loss of precordial T wave balance. That's a sign of early anterior ischemia. And again, that was in a symptomatic patient. Well, the computer called it normal, so the physicians called it normal. They did a couple lab tests. They didn't go any further with cardiac workup, and they discharged the patient, who then was found dead at home the next day, and her autopsy confirmed a big anterior wall MI. The missed finding was those new big T waves, the hyperacute T waves in V1 and V2. Here's another hyperacute type of T wave. 48-year-old comes in with atypical chest pain, and as we mentioned earlier, the abnormality that you've got to pick up on is the initial part of the T wave. I know I'm going through this fast, but we've talked about this before. The normal initial part of the T wave should be nice and concave upwards like you're seeing in lead 1. But if you look out there in lead V2 and V3, you appreciate that the initial part of the T wave is not concave upwards, it's very straight. And when the initial part of the T wave becomes very straight like that, you've got to worry about early ischemia. There's also maybe a little bit of ST sagging out here. The computer's missing it. The computer at triage is calling this normal. Well, when you have any doubts, what do? Say it with me. Get a repeat 12-lead ECG. So again, here's the repeat 12-lead ECG just a short time later. It's 2:51. Notice what's happening to those anterior leads. The J point is rising. You're starting to become a little Wellens-ish, if that's a word. I'm making up words now, but that's what appears to be happening. We'll get another 12 lead a short time later. In fact, let's compare, before we get the next 12 leads, let's just compare. Here's your initial ECG at 2:35, and then here's one of your repeats at 2:51. That was, I guess, number 2 or number 3. I don't recall. But look what's happened there. That's turning into Wellens, and it started with just this straightening on the initial part of the T wave. Whenever you see that, you've got to assume that that's early ischemia and just get a repeat 12 lead. I'm not even saying you cath the patient or call cardiology or echo or troponin. Just all I'm saying is to repeat the 12 lead, and look what ends up happening. You start seeing a Wellens morphology, and then a little while later, before the patient goes up to the cath lab, J point's gone up a little bit higher. Nice Wellens there, clearly Wellens in V3 and Wellens waves in V4, and no surprise, this patient had a big LAD occlusion, which is predicted by those Wellens waves, the biphasic T waves. Case number 9, this was sent also from Toronto by Dr. James Fairbairn. 70-year-old man comes in with right-sided chest pain radiating to the arm. He's got diaphoresis while exerting himself. This is obviously a bad story. Computer's calling this normal. Now, if you look at this 12 lead, I think what stands out is those T waves in the anterior leads are maybe a little bit too tall. I really don't like ever seeing T waves that are larger than the QRS. In fact, you could probably take that entire QRS and fit it inside the T wave. This is almost the same thing. You can almost fit that inside the T wave. That's not normal, and that's something that I refer to as a hyperacute T wave. It's another type of hyperacute T wave. So, as we've talked about, there's 2 types of hyperacute T waves that we've talked about. One is when the initial part of the T wave is very straight, like in the last case, and the other is when the T wave is very large, larger than the QRS complex. If you can fit the QRS inside the T wave, I call that too large of a T wave. I call that hyperacute. So what do you do in this case? The computer's calling it normal. You put him back out in the waiting room, right? Of course not. You get a repeat 12 lead. So here's the first ECG at 11:01 a.m. that we just looked at. Let's take a look. Let's repeat the 12 lead at 11:14. Notice the T waves are getting a little bit taller up there. Let's get another one and see what's happening here. Now the T wave's continuing to be large, and out here it looks like the T wave is starting to dip just a little bit down there. You're getting a little bit of ST segment sagging. Your T wave is still clearly larger than the QRS complex. They get another one, and now take a look. T wave is even bigger than the Kuros complex than it was earlier, and you've also got some ST segment sagging shooting up into a big, tall, symmetric T wave. What's that called? That's called the De Winter T wave pattern, and that predicts a proximal LAD occlusion. Fortunately, this patient had a good outcome. Your computer completely misses hyperacute T waves. Don't rely on your computer to pick that up, and that's an early sign of ischemia. And the last case, this is a 32-year-old man with chest tightness. We talked about this when we were talking about marijuana a few months ago. This only risk factor here was marijuana use, and that's a little controversial of me to call it a risk factor, but I'm going to do it anyway because I'm on a rant here. I'm on a roll of a rant. And this patient ends up getting an initial 12-lead ECG. Take a look at the computer. The computer's calling this normal again, and you've got some kind of large T waves up here. Those would be easy to just say early repull, but the computer is completely missing the ST segment depression in the inferior leads. This patient has reciprocal changes that are developing, and your computer is missing the reciprocal changes. Just like your computer ignores the reciprocal depression or flip T wave in AVL, your computer is missing the reciprocal inferior changes here as well. Key point here is when somebody's having a STEMI, sometimes before the big significant ST elevation begins, sometimes the first thing that begins is the reciprocal findings, and then later the no-brainer ST elevation develops. So sometimes the very first thing that develops in a STEMI is the reciprocal findings. Well, the physician was totally on board with this, didn't rely on the computer at all, and troponin was sent, cath lab was activated. Take a look, troponin is already 6.62, and this patient ended up having a 95% left main. That's the big one, left main, and fortunately ended up having a good outcome. Now, the last point that we'll bring up is this topic of serial, not this kind of serial, but this type of serial. We've talked about serial ECG testing before. We've talked about this study in which they looked at 41,000 patients from a STEMI database. 11% were diagnosed not on the initial EKG, but on the repeat. In other words, if you're not repeating your EKGs, you're going to miss 11% of your STEMIs in this article. Here's another one. In this one, they say you're going to miss 15% of STEMIs if you're not repeating your ECGs, and there's other literature saying that if you're not repeating ECGs, you'll miss up to 20% of STEMIs. So you've got to repeat the 12-lead ECG, otherwise you're going to miss a lot of your STEMIs. So key take-home points as I finish this rant. Point number one. You can't rely on your computer. Even when your computer calls the interpretation normal, you still need to immediately review that 12-lead ECG. Don't trust your computer. Secondly, computers tend to be particularly bad at reciprocal changes, especially in AVL, and also hyperacute T waves. They stink at picking these things up. And finally, whenever there is any concerns, but your initial ECG is not diagnostic, get your serial ECGs. And finally, remember, on the road to success, there are no shortcuts. You've got to look at those 12-lead ECGs. All right, folks, that's it for this week. I hope that you learned a couple of things from these cases, and I look forward to talking to all of you next week. Bye from now.